healthcare to access the best guidelines and learn from experiences from clinicians all over the world. Last week, we brought different areas of training and learning, including primary care and surgery, and also respiratory medicine. This week, we're going to be covering oncology this evening. Tomorrow, we have a session around diabetes and COVID-19 with Professor Partha Kar. And on Thursday, we're looking at end-of-life care. This is the Dying Awareness Week, of course, nationally and internationally. We're looking at how COVID-19 has changed the way we manage patients at the end of their life. But today, it's a great pleasure to introduce two of our most esteemed colleagues around the world. The first one is Dr. Bhavna Sirohi, who's an oncologist working in India. She actually worked with us at the Royal London Hospital in Barts for many years, spent a lot of time training in the UK, working here. And she also did a lot of work for the Royal Society of Medicine around the Global Oncology Forum. But she's here now as an oncologist working in India, and she'll be sharing experiences going forward. So welcome, Bhavna.
Thank you. Thank you. Good evening, everyone.
And of course, we can't have oncology taking all the glory. Our surgeons have to be involved in cancer work at some point. It's a delight to introduce Dr. Jagannath, who really is one of the most premier surgeons in India, having trained virtually every expert you can think of around India. He spent many years at the Tata Memorial Cancer Centre as the head of oncology in Mumbai, and now he's the head of oncology surgery at the Max Healthcare Group. He's also past president of the International Hepatobiliary Association. So it's a real pleasure and honor to have you on our program today. So welcome, Dr. Jagannath.
Thank you, Shafi, and then good to be here with you.
Thanks for joining us. It's late in India and we kept you both up unfairly, but hopefully the hour will pass very quickly. The idea is to really share knowledge and experiences from two amazing clinicians and also from experience from different parts of the world, in India, who are managing COVID in perhaps different ways to our own health system in the UK. So initially what we'll do, we'll ask Bhavna and Dr. Jagannath for some 5 to 10 minute kind of presentations around their understanding, what they've been experiencing in the healthcare system. Then we'll have a fireside chat for about 20 minutes. And then we'll ask you, the audience, to ask questions. We'll try to pose as many as possible to our esteemed colleagues here this evening. So Bhavna, if I can go to you first, would you mind doing a short presentation for us? Thank you.
Thank you, Shafi. I think what you and Medical Realities are doing for education, especially during COVID times, for covering all aspects is fantastic, and I must congratulate you.
Thank you so much.
I'm going to discuss cancer care during COVID-19, and this is based mainly on my personal experiences. And so I think the oncologists and the patients face a unique challenge during this pandemic, and it's beautifully described by my Twitter friend, Dr. Lewis, who is an oncologist, a GI oncologist, and a patient himself. It's between Scylla and Charybdis, if you know the Greek mythology story. So we want to reduce the risk of infection with COVID-19 in our patients, but we also want to make sure that we do not compromise the cancer treatment. And it is a fine balance and a lot of shared decision-making that has to go on with the patients. Now, the lockdown in India started about 8 weeks ago, almost 2 months ago. So the questions we had almost 2 months ago compared to the questions that we have now are different. So we want to know what the current data on care of patients with cancer is during COVID-19. And we've had some studies which have come out from Italy, from New York, from China, which show that cancer patients are more likely to get COVID-19 because of their low immunosuppressive status. And patients with stage 4 or metastatic cancer who do get COVID-19 have a higher mortality. So this is all we know, and it is all based on small number of patients who developed COVID-19. The questions we asked were, was it possible to avoid radiotherapy, chemotherapy, where the benefit is small? And again, we are re-questioning these questions because I think we have to go back to the new normal. Can treatment be delayed? Can we shorten the duration of treatment? For complex cancer surgery, I'll leave it for Dr. J. So we've had a lot of these algorithms, frameworks which have come out for prioritizing cancer treatment during the pandemic, which put into lower priority versus higher priority. And when I have a patient sitting in front of me in the clinic, it is very difficult to put any of these patients in these boxes, because for me, a patient may have stage 4 cancer and may need palliative treatment, but the patient may have a 5-year survival, which is 40% or 50%. So I think it is very difficult to say that, don't prioritize palliative treatment and prioritize just curative treatment. Very difficult choice for clinicians and patients as well. So the cancer care during lockdowns, I think very important, good communication, fantastic, and minimize face-to-face contact. These are the general principles. And I think the other thing we have to do is, and one of my friends, Dr. Matthew, suggested it, we have to tailor it to the extent of community spread. Like Kerala has actually successfully stopped transmission in India. So the care of cancer that you will consider or discuss with your patients in Kerala is going to be different from Mumbai, where Dr. Jagannath is going to be different from the care in Delhi, because it does depend on the community spread. It's a great point that he's made. We have to prioritize treatment. We have all started doing video consultations. I piloted this when I was at Bath's Health in London. And what we learned from that pilot was patients don't want phone calls. They would prefer to see the doctor at the end of a phone. And I would prefer that as well. We've all started doing home blood tests, I think, which we should continue, home delivery of oral drugs. I think there are a lot of some good things which have come out of this pandemic. And these are some things which I think I would continue doing it in my practice. Modified treatment, shared decision-making, nothing has changed. We've routinely started using GCSF. And again, there's a cost involved to it. Chemo port flushing, we used to do it every 3 to 4 weeks. And we had a consensus with oncologists all around the world, and we've extended it to 10 to 12 weeks, which is great. I mean, it decreases the footfall of the patient in the daycare. Daycare, again, these slides are available actually to be shown. I'm going to just stick to 5 minutes. And these are the things that we have done. PP for staff, patients, not allowing attendance is the most heartbreaking thing for me, because for cancer patients, especially in India, most patients come with 3 to 4 patients. In UK, when I was there, yes, maybe the average was 1 attendant. But here it's very difficult and hard, again, very difficult for us to stop this. But I think it was important for us to do that, to reduce the footfall in the daycare. The other thing which we did was, because mental health for doctors and patients is very important. So we have started the online support. In fact, this Monday, we made it global. So we had patients from Dubai, London, and all over India join in as well. We do every Mondays at 6. Have their guidelines. Briefly, I want to touch start. We want to healthcare courses for training, and we at the end of the year. But I think given that
we just lose you slightly, Bhavna, can you hear me? Bhavna, we may have lost you. Can you hear me? We'll just see if we can get Dr. Bhavna back. I think.
Sorry.
Can you hear us?
Did I just? I'm really sorry. I will. I'm just about to finish just 2 more slides.
Yeah, no.
So I think stage progression is.
We lost your audio, but carry on, please. Thank you.
So I think stage progression is time dependent, and cancer does not for the pandemic. So I think we have to restart screening, especially where we know it has a cancer-specific survival benefit, like for colon cancer, breast cancer, and cervical cancer, which is a common cancer for us in India. So these are statistics for UK. I mean, in April 2019, we saw 30,000 new cancer cases, and this year it's been only 5,000. It's a huge drop in diagnosis of cancer. So I think when we look back in 2025 at cancer mortality rates, I think we'll be ashamed that we didn't do more. So as oncologists, I feel we need to shout from, these are his words, to shout from rooftops about long-term impact of the pandemic and do something now for our patients so that their cancer care is not compromised. And I totally understand the logistic issues that each trust or each hospital or all the countries, all the LMICs might have. My friend Harmala wrote this, and I think it resonates with me as well, that I understand the need for extra precautions when treating people with cancer who are immunocompromised, but placing them in a situation where they have to choose between cancer and COVID-19 is unacceptable. I wrote this editorial right at the beginning of the pandemic, which is something now I'm trying to move away from, because I said that, we may end up under treating patients and may compromise outcomes and may compromise their 5-year and 10-year survival outcomes marginally. And by ignoring the real risk of COVID-19 now. But now we know what we didn't know 8 weeks ago, that, it's here to stay. So we have to practice social distancing, hand washing, masks. And we have to help our patients and oncologists redefine the benchmark of cancer uncertainty. And for that, research is very important. So we've started at Max, looking at real world evidence on effects of de-escalated and adjusted regimens or protocols on cancer patients. And I think this is something that I think we all should be doing and learning from. And these are the other research protocols which will actually help us learn more about COVID. Sorry, Shafi, I've overshot by 1 minute.
Not at all. It's more important to hear about what you've learned. It's been absolutely fascinating to hear about the workload and how you're managing it. So if we can stop sharing that screen now, then we can go on to Dr. Jagannath and really talk about the other elements of oncology, which is surgery, of course. We know that often surgery is a primary treatment of choice in some patients, not all. Otherwise, it's complementary to other modalities. Dr. Jagannath, can you tell me about your experiences so far in this context of COVID-19 and surgical practice, not just yourself and your hospital, but throughout India? Just give us a little overview if you can.
Thank you, Shafi, and thank you for giving me a global audience. Just a little background of India, how we tackled the COVID. Right now, as I speak to you, there are 2,300 deaths, 2,335 deaths in India, as opposed to 32,000 plus in UK. Mm-hmm. And I don't even want to talk about United States. That's a complete outlier. Now, the first phase when we had was a preparatory phase. We are in a lockdown, a strict lockdown for the last 2 months. The preparatory phase was all the hospitals were kept ready for a tsunami of COVID patients. So all the elective surgeries were kind of kept in abeyance. All the patients with cancer, we told them that nothing is going to happen in 2 weeks' time and you can still hold on. But then the tsunami did not happen. And then none of the hospitals were overwhelmed by COVID patients. So we started elective cancer surgery. Now, the one of the logistics issue was about the lockdown itself, that patients were not able to move from place to place. We must understand that simple surgeries like breast, etc., can be done in a local environment, but a complex surgeries, which what I do, HPB surgeries, need to be centralized, which was becoming difficult for the patients. But I must say that the authorities have cooperated very well and were able to do complex elective HPV surgeries and colorectal procedures in the hospital. Now, the first phase was to separate the COVID on COVID wards very clearly with the staffing. And once that happened, we were very sure that we will not have any patient coming to the hospital who would turn COVID positive. So that safety was very much important. Then we had a very clear discussion on the resource allotment, because one last thing we wanted to do was that our OR staff, our rest of the support staff are kind of drawn to elective lists. So we are working at about 50% of the capacity, but able to do most of the elective surgeries. Now, how do we then categorize what are the patients to be taken or prioritized for surgery? Obviously, all the curative surgeries or potentially curative surgeries will get a priority. Second thing is the histology is important. Suppose it's a neuroendocrine tumor, which is relatively slow growing, grade 1, I can wait for some time. I would rather put a colorectal back again. Yeah. The second is about the about and then intensity of surgery. Right now, we have to take surgeries which are not very extensive. Like I won't do a hydrocoloniocarcinoma at this point of time because I know that it's a strain on the resource. But I can certainly do an anti-resection or a colonic resection very comfortably in the current environment. And finally, the protocols for safety has to be very, very strict. And this is something which we have realized that unless we have a good protocols in place, both for COVID and non-COVID patients, we'll be getting into trouble. What I really see the positive benefits of this pandemic are one, the telemedicine. Most of my consults are on remote consults. Patients need not travel at all. And they literally send on a WhatsApp video, nothing fancy. They send their reports. I see them, I talk to them face to face and advise them. All my follow-ups are on remote consult. So this is something which we have to realize that patients need not travel anymore for the regular follow-up visits. And like Bhavna said, I must say that Bhavna is a very progressive oncologist of trying to reduce chemotherapy. And this time they are forced to reduce chemotherapy. So you're not called for every to the hospital for a 5-year infusion. And oral tablet is going to be fine. And that's why it's very interesting for us to see whether there's any detrimental effect or not. And let me tell you, my own feeling is there will not be any detrimental effect. I think we're going to be fine. And I also pushed up surgery a little bit, like in radiation. Earlier on, we used to have a long course radiation for rectal cancer. Now we'll say, okay, 5 days radiation, send them here for surgery, and we are done with that. So visits to the hospital become less. So on the whole, we are seeing I would say, many positives. The number of relatives coming in are much less. The number of visits to the hospital, much less. Remote consults, excellent. Follow-up program, much simplified. So on the whole, I would say that we'll possibly end up with a more balanced cancer care overall. So that's my hope that, we will be able to do a simpler, safer, better care for the patients.
Thank you so much for that. Thank you for that great summary on where you are in India. So I'll start asking a few questions and just having a conversation around this whole topic, of course, which is absolutely fascinating and requires some kind of navigation through the mild complexity in these cases. So in terms of surgery, have you noticed in India less patients coming through emergency? In the UK, for example, we've seen 50% less strokes coming through the door, less heart attacks, also less appendicitis, less perforations of diverticulitis, for example. We're not quite sure where they are. I assume they can come at some point. Are you seeing the same?
I know.
Fearful?
No, see, I think before the elective surgeries, most of the staple surgeries were all appendicitis and gallbladders and so on. Now, we must understand one thing. In a referral setting like in Mumbai, where right now we are at the height of the peak, in all likelihood, most of the patients would be managed locally, and they would not want to travel all the way to a high endemic zone. So, which is fine. So that kind of a decentralized care for most of these common procedures is absolutely fine. In fact, that's a lot safer than they coming to a hot spot like in Mumbai.
And that kind of, I guess, makes sense from that perspective. So let me ask another question in terms of surgery. If you had a patient who was COVID-19 positive, also had cancer that was treatable, for example, how do you go about managing that? What's your principles?
Now, it is active COVID-19. That means it's RT-PCR is positive.
Yeah.
There is a 20% mortality in the elective surgeries.
Yeah.
In those situations, I would rather wait because we know very well that nothing is going to happen in 2 weeks' time. Might as well have the HRCT of the thorax completely clear because many of these people end up in respiratory problems and we may be just hitting them just before the cytokine storm. So much better to ride over and then take them up as electives once they're through. We have to understand one thing. It's not a simple flu. Many of them are quite weak. They need time to recover. Give them time to recover and then plan for surgery. So as a policy, we are now doing an RT-PCR test before surgery for our patients before we take them up for surgery.
Thank you. That's really helpful. And to the audience, please use the question answer and also raise your hand if you go to participants. If you ask a question, we'll ask the question by text, or we can go live to you through the audio connection. So think about what questions you can pose to our esteemed colleagues. So we mentioned the fact that this is the new normal. And of course, telemedicine has become so useful in the situation. And Bhavna, you've always been a kind of a visionary, pushing the boundaries of what's possible technology and the way we connect with patients for a long time. So I guess you're ahead of the curve. You thought about this a long time ago that this was coming. So in terms of telemedicine, what's been your experience now for not you, because you're kind of the expert, for other people now saying actually something we can also use? How have you disseminated that knowledge and that information?
So I think most of my... Yeah, Dr. Jagannath, you go ahead.
No, this the telemed is something which we have started using from last year, because one of the major problems in India is just the sheer travel for a longer distance. Yeah. Flights, two people coming in. So we thought that let's try telemedicine. It was very, very successful, and patients really loved it. Yes, some of them really want to come over and then be seen by you. That's more of a personal choice. And we can also direct the kind of investigations which we can do. And right now, I think the technology is pretty simple. It's just a simple. I mean, we had an app, etc. But now, right now, it's a WhatsApp. Nothing more than that. Now, most of the hospitals, because they are completely short of OPD patients, they are forced to take up telemedicine as an option. And I'm sure that Bhavna will tell you that it's become an absolute necessity for any hospital to kind of service the patients.
So I think telemedicine, I think patients prefer video consults. I do as well. So, I was able to examine patients like jaundice. You can see the lump. You can assess the redness of the lump. You can see if the patient is responding. The lump is going down. So there are a lot of advantages. And the key advantages is that, patients, when I was in London, I think the best advantage for the patients was that they saved money on travel. And the second thing is they were able to continue working. They could do the video consult. They didn't have to arrange childcare. They didn't have to arrange, take a day off, half a day off to come and see the doctor, sit in the OPD, wait. So I think patients loved it, and the London Digital Collaborative, I think, was going to take it forward in a big way. And now that this has happened, this is something like we were prepared for. And I think in the future, there are some situations where I would prefer face-to-face consults, and patients would prefer that as well. And they've said that. So when you have a new patient who has been diagnosed, you would like to examine the patient, and you need about an hour of chat. And so I was very distressed last week when I gave the diagnosis of breast cancer to a new patient, and we were talking about hair loss on chemotherapy and removal of breast. For a woman to lose hair and lose breast, it's I would normally go and hug the patient. Yeah. I would normally hold her hand. So with the social distancing and everything, it was distressing for her, distressing for me, because I thought, if I went and even hugged her in case, I give her an infection if I have it. I mean, even though I was COVID negative a few days ago with test. So all of these things, the second scenario where I would like a physical consult again is when you're giving a scan result, when you're breaking bad news. It's very difficult. You don't know who the patient is with at home and what the circumstances are at home. So these are the only two scenarios that I can think of where I would prefer a face-to-face consult. Otherwise, I think video consults are here to stay. And I think we all as doctors and physicians must adopt it.
And I think you're right. What COVID-19 has done.
Happy to add to that. I think the first, as a surgeon, you must agree that the first consult where you want to plan a procedure would largely be face-to-face and in person. This is very important because you have to judge the kind of a personality you have in front of you. And most of it is not really clinical, not really medical. It's largely supportive. And that's a very important role we as professionals dealing with cancer have it. I think more than anything, more than a surgeon, I'm a support group. I mean, I give them support because the first diagnosis, you literally, the floor opens up and then you start sinking in. You need to really hold their hands and build them up. And the follow-up visits, they're already stable, and then that we can handle it.
Yeah, so I think I agree with that. And I think one of the things we've got to go back to is we teach medical students and trainees on face-to-face contact, on clinical examination. We need to change medical school, don't we, both of you? Because now we're changing the way we diagnose. Yeah. Now it's about history taking, it's about viewing on telemedicine platforms, and the old hand-touching feeling is changed. Yeah. Do you think we'll ever get to a stage where we can break bad news? This is a controversial area. I remember about 6 months ago, there was a lot of media coverage on a doctor in America who'd broken bad news by TV on a telemedicine platform, and he was almost castigated in the media. This wasn't right. But now, of course, it's the new normal. Perhaps he was ahead of his time. Do you think we could ever break bad news in that way? Is human contact going to change, Bhavna?
So I think already one of our colleagues at Arts, actually, Satya, his experience was different that, and they have, and I can't remember the name, somebody else had piloted this where they did give breast screening results on video consults, and they told the patients that they had cancer. But there are, I think, certain things that you have to keep in mind who the patient is with. I think we should be able to give bad news. Only thing is we have to set certain boundaries and rules to make sure the patient is well supported at home. I think this is doable. And if I remember, I think it was Satya. They said that patients actually preferred getting it at home when they were in their own surroundings, rather than having to travel all the way and then go back, depressed and being given the bad news. So actually, you have both sides.
Yeah,
I think it will change.
I would not break the bad news in on a screen because see, let's look at the from next week onwards we are going to travel. Maybe from June onwards we will travel. We will travel to a mask. We'll travel with all kinds of social hygiene and social distancing measures, but we will travel. So sometimes there is one more option if really the patient cannot come, is to have an intermediate medical professional with the patient. So you communicate through another colleague of yours whom you know well in the same city or the same thing, who can actually carry on the role along with you as far as breaking the bad news is concerned. That will be kind of a way forward in case the patient cannot come. Shafi, there are some few questions coming up. We'll go
to those in a moment shortly. One more question for the panel here is around the cases that are not coming in. In the UK, we're missing about 2,500 cancer cases per month because they're not being seen, they're not being screened, they're not having the diagnostics, etc. And you mentioned even a bigger number, of course, in India. So what's going to happen going forward? How are we going to manage those cases that are not coming forward at the moment? Is there enough capacity? Are they going to be late stage? I mean, what's the readiness like for these patients that might come through later on?
So I think we'll have a spurt of cases and very likely patients in advanced stages who are going to come up. I mean, recently I've seen a couple of patients who've come up when the performance status has declined so much that, it's not possible to treat them.
Yeah.
And performance status is one of the great markers that we have for considering patients for palliative treatment. I think patients are waiting long because they're scared to come to the hospital, or scared of catching the COVID infection. So that's why the cases have gone down. The second thing is the screening programs have stopped.
Yeah.
So we've stopped picking up new cases. So I think these are the two major factors. And the third thing is lockdown.
Yeah.
Patients are not able to travel. Even I mean, even if they are unwell, unless they have a real emergency.
Sure. Okay. Let's go to some of the questions. So we've got a couple of people who raised their hands. So we'll go to Ips Rishi first of all. I'll just allow you to... Ips Rishi, are you on? Can you hear us?
Yeah, I'm on. Hello everyone, and hello doctors. So I'm an aspiring medical student from England, and my question is about technology and how it's going to develop, because let's take India for example. There are different types of people. So there are old age people and there are people who are poor, and obviously the ability to have the best technology, maybe to even video call a doctor or to call a doctor, is, there's a range. And for example, my grandmother, she lives in India, and she had a stroke and she was unable to video call a doctor because, she doesn't have the latest technology and she wasn't able to get the best help. She's okay now, but, there are going to be some barriers with poor people, some old age people, and technology is not, yet suitable for everyone. So how do you think we're going to overcome this issue?
So I think that's an excellent question. And so I've had a lot of experience in working in rural India. And what I found was that I worked with Asha and Anganwadi workers who are healthcare workers in rural India. I trained them, and that was in Bangalore, in UP, in Punjab, Rajasthan, so both North and South India. So what I found was most people in India, even if they're driving a rickshaw, they do have phones, and you may not be, and quite a few of them actually have smartphones, which are the cost of which has gone down quite significantly. And yes, they may not be able to do a video call, but they can. We can do a teleconsult where you can call them. But I completely understand, what you're saying of challenges. I have quite a few elderly patients who, I have myself downloaded WhatsApp on their phones and tried to show them rather than writing to, do this voice call. So I've done that with quite a few of my elderly patients in their 70s and 80s. And sometimes, you've taught them and then they call you and ask you whether you've received the message. So it completely defeats the purpose of WhatsApp. So I think there are a lot of challenges. I completely agree with you, but I think it is doable. Maybe not for everyone, but for, I think, majority, this is something which I think can be considered, having worked in rural India.
Dr. Jagannath, views on this?
Rishi, this is a great question. Now, I think one of the positive fallouts of this pandemic is going to be a huge growth in technology. I think nearly about 800 startups are working only on telehealth. So what your grandmother has faced, 200 million smartphones are there in India, and even growing by numbers. So soon it is not at all difficult for us to reach out to the last mile in India. There will be intermediaries, like, for example, like what Bhavna has mentioned about the ASHA workers, the local GPs, who will be facilitating this kind of a conversation with an expert in the city. But this is going to happen, and this is going to actually accelerate the whole process of driving the healthcare down to the last mile in India. And not only in India, it's going to happen across the world in the same fashion.
I hope your grandmother got the care she needed, Rishi.
Yeah, she got the care because obviously we obviously tried to call doctors in India. She's in Kolkata, and okay. We called some local numbers, and everything was sorted out in the end. She's much better now. Thank you for asking, doctors.
Ips, thank you so much for your conversation and question. And we're just going to meet you now. We've got Hareen Elaya Thambi, who's going to ask the next question if you're available. I'm just going to put you on to there. Can you hear me, Hareen?
Yes, I can hear you.
Lovely. If you just tell me who you are, where you're from, and then pose a question to our panel.
My name is Harini and I'm also an aspiring medic. I posted my question, but I'll ask it. So I wanted to know, what do you think the after effects of COVID-19 will have on cancer care and cancer rates?
I think Hareen, we are still learning about COVID. We know how cancer patients behave if they do get COVID-19. As you know, few papers have come out from Italy, US, and China, showing that the risk of mortality is very high in cancer patients. And but we don't know what the long-term impact of COVID-19 is going to be on cancer itself. We will know about survival data probably 2 years down the line, 3 years down the line, and whether what the decisions we have taken today with the patient has significantly compromised their care or it has not. Because, you know, all of us have tried to work very logically. So where, you know, I'll just give you an example. So where we were giving FOLFOX chemotherapy, which is infusional 5-FU, now there is a randomized trial which has shown that, you know, infusional 5-FU is non-inferior to capecitabine. But capecitabine has more toxicity. So as clinicians, when we discuss with the patient, patients don't want to take capecitabine, especially in India. So now I think what we have done is we've stopped the infusional bit and switched to capecitabine. So there are a lot of things we have done like that in elderly patients with comorbidities. If they have a hormone positive breast cancer, we switch them to endocrine therapy. So I think we will know the impact of our decision making with 5-year survival figures.
Thank you. Dr. Jagannath, what about the surgical aspects after this? I mean, are you actually performing elective surgery at the moment that's non-cancer at the moment?
No, I am a surgical oncologist, so all our cancer surgeries, but so we are doing elective surgeries.
Okay.
We are doing elective surgeries to the extent that we are not loading the system, because one of the questions is that how do we accommodate the patients? We just have to make sure that we are not overloading the system. And I can see that within a matter of, I think, next couple of weeks, we will be doing 60 to 70% of our usual load of elective cancer work. So I can see that happening, because our initial feeling was, oh, this is going to go away. Now we know that, oh, it's not going to go away, but we have to kind of, adapt ourselves to it. I must tell you one thing, Shafi, and for all the whole group, is that I would say this: when you defeat fear, you defeat COVID. Right now, it is the fear which is overriding rather than any kind of a logic. And if you defeat the fear, then it starts becoming, okay, it's also there, and then we are also going to be there. Fine. You go to East, everywhere in Hong Kong, in Japan, they wear a mask. We wear a mask. So that's going to be the new social practices. That's about that.
Yeah. So
waves will come and go. Waves will come and go. I don't think we need to bother about the media throwing numbers at you left, right, and center. We need to be careful, and that's it.
So how is India managed? Just a slightly different point. But you mentioned earlier, for a population of over 1 billion, you have about 2,000 cases or so. In the UK, deaths, that is, we have over 35,000, maybe 50,000 deaths if you count the care homes. The population of about 60 million. So how has India managed this, to lock it down, to manage it so that you haven't changed appreciably your clinical contact and work? What lessons can we learn from that?
Honestly, I'm also surprised how this 1 billion plus people actually stayed home and then, just had. But it's a remarkable thing, because I think some of the pointers have come from like Italy, when, the skyrocketing cases and all that. So people were genuinely scared, and they just took, stayed home. That was, lockdown came in very early, and the flight stopped, domestic, international, strict lockdown came in very early. That was one good thing. So the hospitals had time to prepare. So we are going to see the numbers. Make no mistake that once we open up a little bit, we are going to see the numbers, but we are not going to be, the healthcare system is not going to be overwhelmed by the numbers. So once again, I would say that we will get back to a fair amount of normalcy along with the virus, taking some precautions. That's about that. And some good precautions, let me say, very good precautions, and then we are through.
And how have you found operating in PPE? Obviously, it's not easy. Does it affect the surgery itself? I mean, because obviously you get tired, you get dehydrated. you're under PP for quite a good
Fogging.
time.
Yeah, yeah.
Any thoughts?
See, I would say it's a, it's more of the dehydration, as you rightly say, is the problem, because you really feel thirsty after some time. Apart from that, I would say that we now got used to it. We used to do it for Hep B, HIV, and so we used to have some kind of a PPEs, but we're able to manage surgeries. That's why I must say that we should not take up very complex, long surgeries. I won't do an 8 to 10 hour surgery like a hyalocholangiocarcinoma, but I would certainly do a shorter procedures like 3-4 hours, 2 hours procedures. That should be absolutely no problem at all. So if it is a long procedure, maybe fine. You may need a break and then get back. So apart from that, we are able to manage pretty well. Yes, you feel thirsty, yes. Yeah.
Everyone's got the same robustness that you have, Dr. Jagannath, but we all try, of course. Bhavna, you're obviously a lot of chemotherapy to our patients. Have you noticed any patients declining chemotherapy because of the immune response? I mean, what's been the conversation you're having with them? Some must be concerned about having chemotherapy at higher risk, for example. Has there been a change in their acceptance of your regimens, or have you had to modify it?
I think it's the C, I say the C for cancer and the corona. Both of them are quite scary. And patients, most of the patients that we've had, if we have a discussion about the risks and the benefit, if the benefits are high, like let's say if you have a patient with lymphoma, even if they are elderly, but they have a lymphoma, which would be immediately life-threatening, and then you have the potential threat of COVID, so patients would go for it. But if you have a patient with pancreatic cancer, where the benefit with chemotherapy is very small, and palliative chemotherapy maybe will add another 4 weeks or 6 weeks to their lives, I think these are difficult conversations, very long conversations, and all of us as oncologists have had these conversations with patients. And some patients have preferred to have chemotherapy. I would say most of the patients have insisted that despite all have to recommended Ayurvedic treatment. Say 100 patients, I would have about 1% of it, sadly. Dr. Jagannath will have the same experience as well. So,
No, I can tell you one thing. The fear of cancer overrides the fear of COVID. This is clear. I have a patient now who was in Jaipur, diagnosed with rectosigmoid cancer. He took a car because of lockdown, traveled 1,000 kilometers to Mumbai for surgery. He says, absolutely, my treatment for cancer overrides all the fear of COVID. I'll take care of that. So this is exactly what's going to happen in the future. Once they get fairly comfortable, the fear factor goes off. They'll seek and come for surgery, because cancer is something which you cannot just brush away. And COVID is something which they'll realize that we all have to realize that we're going to live with it. So the treatment of cancer will have to continue more or less the same way, except some modifications, largely from the oncologist or progressive like Bhavna, who will do less of chemotherapy when there's not that indicated, which he rightly said. If a pancreatic cancer comes in with advanced metastatic liver, it is maybe a good idea not to put him through a lot of chemotherapy. So that's kind of change in perspective which is going to come.
Thank you. I'm just going to go to one of the audience members called Isabella Cressel. If you're there, Isabella, I'm going to allow you just to, we can't, I don't think you can talk. I think you've got an older version. Okay. Isabella, if you can put your question onto the Q&A, so I think your Zoom version isn't allowing you to talk to the panelists, but we can certainly get your question on the Q&A. While we're going through that, let's talk about the other issues. So if you look at a wider picture of public health, we know that public health is going to be the key for a pandemic. The UK, we've not had many pandemics. And we know that if you go back a few years to the Sigma kind of scenario simulation, we didn't pay heed to the attention what we learned a few years ago at government level. Did India have more experience in managing pandemics generally? They were more ready for this pandemic. Do you have simulations from the government on a regular basis around this? I'd like to know more about that.
I mean, I must say that no government was prepared for this kind of a pandemic. You know, in most advanced countries, I won't say most advanced when you take, no, it's not the most advanced, United States. Rest of the countries who did not prepare or did not even believe in the pandemic. India was not prepared for pandemic at all. There's no doubt about it. But what we have to see is that the reaction to the impending threat was immediate. So that was good. So there are no systems in place as far as prevention of pandemics is concerned. And that is one big reason why people thought that in India there will be millions of deaths, which did not happen because thanks to the proactive and very clear decision making at the government and the people. I would give a lot of credit to the people who have followed the guidelines properly. So are we going to be prepared in the future? I think possibly yes, we will be prepared well for the future. The public health system has to be strengthened substantially. Then only we'll have some kind of an answer for the next pandemic, which is if at all it occurs. So one factor which is important for India is to strengthen the public health and primary healthcare system in a big way.
Okay, I think we've lost Bhavna, I think, from that perspective. I think hopefully we'll get back in a minute or so.
Yeah.
I guess going forward, I mean, did you have problems with PPE, Dr. Jagannath? We had huge issues here in the UK with PPE and protective equipment for our staff. Did you have the same problem in India?
We did have, initially we did have, you see, very surprisingly, every single country of imported PPEs from China. Every single country imported everything from China. That's the whole problem. So PPEs suddenly disappeared because of shortage globally. That's the reason why I feel that because we could flatten the curve substantially, we were able to manage. Now is the position, okay, fine. We produce about 2 lakh PPE per day and then distributed across. So we are fairly self-sufficient. Initial phase was bad. Definitely the PPEs were not available and then there were patients were coming in. So that was not a good situation. Now at this point, I would say that yes, we are okay on the PPEs. We are okay on the PPEs and N95 PPEs, we are fine. But initially we struggled. There's no doubt about it.
Yeah. So Isabella has actually asked a question that I think we've kind of talked a little earlier around the missing cancer patients for now that might lead to a future spike in more complex cancer operations in the future due to a late diagnosis. The question is, will we need more resources to cope with this if that were the case? Or do you think you can manage with rejuggling your priorities?
I have a feeling that we are going to see a bit of a burden, but as far as the elective cases which are going to come, complex cases which are waiting, and who will be able to travel, yes, we are going to have a load on that. So we need to kind of manage the load in such a way that, like the usual clinical practice, if someone is having an obstruction, we take them up first. Otherwise, we wait for some more time. So this is bound to happen. One of the problems which has happened in diagnosis was most of the scan centers were also closed. So people didn't have access to good imaging. Now, once imaging starts off from next week onwards, so we will have people getting diagnosed and people traveling and coming along. So we will have a little rebound load in the future, but we should be able to handle it. See, the best part of it is that we are not loaded with COVID-19 patients. Yeah. So I tell you the figure in our hospital, there are 2 patients in ICU, just 1 patient on ventilator. That's it. Amongst we have marked about 150 beds in the hospital. 1 patient on ventilator, 1 patient in ICU, rest of them are just getting better. So that is the story of, except I don't know about Bhavna, what is that, but the kind of, very critical patients we are not seen. I don't know whether it's a question of the hospital, But across, if the deaths of 2,300 means that there are not that many critically ill patients going through the cytokine storm and the multi-organ failure. I don't know, Bhavna, about what's happening in your hospital, but we are fine.
So I think we again, learning from Italy, we designated, I mean, we're lucky that we have quite a few branches of Max within the capital region. So we actually have designated one hospital in Saket as completely COVID, and all the other hospitals have been designated as green and non-COVID. So I don't know exactly the number of patients who are admitted there. But one whole hospital, which is about 200 bedded, has been designated as COVID, because I think, again, learning from Italy, that we keep them separate.
I'd like to go on to another area for cancer patients, which is palliation, Bhavna, and also end-of-life care. So we know end-of-life care has been managed differently, not the same kind of face-to-face contact. If patients are COVID positive in the UK, we're not allowing relatives to come and say the last goodbyes, etc. Are you seeing any problems in terms of palliative treatment? Are you deciding not to go palliation for patients? And how are you managing the patient themselves at the end of life kind of treatment?
So I think in most of the Western countries and UK, we are lucky to have things like do not resuscitate and advanced directives, but we don't have that. We don't have DNR in India. It's illegal. So I work with a charity, Can Support, which does provide end-of-life care in people's homes, and two amazing palliative care specialists at Max. So I think palliative care has continued to go on. We've had challenges providing palliative care at home because Can Support goes to patients in their houses in very, very resource-limited, poor localities and slums. So to have PPE, to try and practice social distancing, I think it's very easy for us to sit here and talk about it. But on a practical level, when you go to these slum areas, and it's very, very difficult to do. And I think Can Support is doing a fantastic job in getting morphine to those patients, in doing wound dressings, in teaching them nasogastric feeding, in doing acetic taps. So I think they are trying to replicate what end-of-life care at home is done in UK, in the NCR region. But again, the teams are very limited in where they can go and cannot go. Because just because of lockdowns, I had a patient who had to cross UP to come to Delhi, to come to Haryana. And the number of permissions that we had to get, and again for Can Support, for the doctor, for the nurse to go to a patient's homes. So I think all of these challenges are access challenge is quite real in India.
And are these patients able to afford the treatment? Obviously, with no jobs, lockdown, no salaries being paid, for example, how are you managing the economic outcome for those patients, both of you?
So I think just talking about me, we are a private hospital, but we do have a charitable side as well, which does provide free care for 10% of our patients. Can Support is a charity which provides free care, so they don't charge patients anything. So all of this care is provided free at home, but it is only those patients who can get to Can Support and who get to know about this charity. In South India, you have Pallium India, which does a great job. So I think places like AIIMS and Tata Hospital, a lot of government and public places have prioritized care, where curative patients have been given more priority than palliative patients. And this has been published as well, which is sad, because I think palliative care is a very important part of cancer care. And yeah.
And Dr. Jagannath, surgery, have you changed the way you operate? I mean, you've got options of open surgery, laparoscopic and robotic. Are you still doing the same kind of operations, or are you deciding actually we'll go for the open operation here because of high risk? I mean, how's that judgment made now?
See, I think we are erring on more on open surgeries now. The reason being that, you want to reduce the OR time, you want to reduce the cleaning of material, and you also want to reduce the resource allocation. This is that if you have a high-tech equipment like a Da Vinci or something, so you need also people to manage that. So it's much better to keep it simple open surgery, quick surgery, and that saves time, and that saves OR time and OR staff. So that is the shift in the approach. So that's one thing which we have done. I think as far as you're also a colorectal surgeon. So earlier on, we used to do just about 50% stoma in a lung dissection. Now we are a little bit more on a stoma because we don't want to manage any complications in this patient. And as a previous question, yes, insurance, the special COVID insurance is coming now. A lot of insurance companies offer an extended benefits for in this particular period. So that's adding to the benefit for the patient. So some kind of mitigation of the financial burden is there.
Great. That's really helpful. That's what I thought might be true. I'm just going to launch a poll here. I'll ask questions so that you can please give some feedback in the corner. All the people that are watching, so we can get feedback and move on the conversation. So I guess the last really point round is let's be positive about the future. Okay. Obviously, it's depressing. The world is locked down. We're under heavy pressure. Give me just a few bits about the future, Bhavna, you'd like to see happen over the next 6 to 8, 12 weeks in cancer treatment.
So I think patient safety comes first. And as long as safety is taken care of by following all the procedures within the trust or the hospital, I think we have to try as much as possible over the next few weeks or in the future to try and ensure that the cancer care is not compromised, and also educate patients to come to the hospital and not ignore symptoms, and hopefully start cancer screening as well as soon as possible.
Dr. Jagannath, let's get your last thoughts about.
I'm a stubborn optimist. So
I've noticed.
I feel that we are getting into a phase where patient safety becomes really important, and we are going to take extra precautions for that. I don't see any decrease in the number of surgeries. I do see a little temporary setback as far as the imaging and diagnosis is concerned, but that's going to bounce back. So it is fundamentally dependent totally on the society. If we behave well and we can contain the waves, we'll have a reasonably new normal going along. So I am optimistic about cancer care. I don't think we are going to have a severe dip in numbers as far as the future is concerned. So and people will get over the fear, and they'll get back to seeking treatment for cancer in time.
Thanks very much. So as the poll's carrying on, I'll just do a quick sum up of this. So thank you so much for joining us, both of you. I know it's late at night in India. I think you're about 4.5 hours ahead. So it's high time that you probably snuggled back into bed and got some rest for tomorrow's work. Thank you for joining us. We've really enjoyed the experience. We had a lot of questions and we'll be pushing out to our social media. Please finish the poll. So let's say tomorrow we'll be having another grand round on diabetes with Professor Parthakar, who's the National Director of Diabetes in the UK and also part of the GERP. And on Thursday, we'll talk about end-of-life care as part of the Diabetes Awareness Week in the UK. Thank you for joining us. Thank you so much for taking time out, both of you.
Thank you.
We'll talk to you both.
Thank you, Shafi, and thank you, Bhavna. Good to see you always.
Thank you. Bye-bye. Thanks so much.
Bye-bye, everybody.
Thank you very much.
Defeat the fear, then you'll be fine. That's the message. Defeat fear and you conquer corona. Yes.
Very kind. Thank you so much. Thank you. Bye-bye.